Good morning, everyone, and welcome to BCRP 2019 webinar series. Today, our speaker is Dr. Jeff Brubacher. Dr. Brubacher practices emergency medicine. He is also an associate professor in the University of British Columbia Department of Emergency Medicine and director of the Emergency Medicine Research Program at the Vancouver Coastal Health Research Institute. Dr. Brubacher's research focuses on road safety with an interest in drug-impaired driving and traffic policy evaluation. Jeff received a Scholar Award and Health Professional Investigator Award from the Michael Smith Foundation for Health Research. Dr. Brubacher is the principal investigator on an investigation of the role of cannabis in motor vehicle collisions. This research is funded by the Canadian Institute of Health Research, Health Canada, and Transport Canada. Dr. Brubacher will be presenting on cannabis and motor vehicle collisions. Please note that the audio lines will be muted during the presentation. At any point during the presentation, you can type questions and comments in the webinar chat box. After the presentation, we will open the phone line and ask questions in the chat. We are now ready for the presentation. Dr. Brubacher, over to you when you're ready.
Thank you. So I'm going to talk about cannabis and motor vehicle crashes. I want to tell you a little bit about some of the research we're doing here in British Columbia and across Canada. And then I'm going to talk just briefly about two tricky problems. One is exposure in people who are habitual or regular cannabis users, and the other has to do with a new problem that we might be seeing now that edibles are legalized. Make the next slide. Okay. So I'd like to acknowledge my co-investigators, and especially Herb Chan and Shannon Urdelli, who've helped immensely, but we have a large team. And I'd also like to acknowledge our funders. I have no conflict of interest related to start with, I want to talk just briefly about some basic principles. So cannabis, the brain, throughout the brain, there are receptors for THC, which is the active ingredient in cannabis. These are the CB1 receptors. And when THC binds to these receptors, it causes inhibition. It inhibits the release of neurotransmitters, so it essentially slows things down. The clinical effect, the reason that people use cannabis is people feel relaxed, they feel happy, euphoria. Sometimes you see the opposite, you see anxiety and even panic. But the desired effect, euphoria and relaxation. Unfortunately, it also causes some degree of impairment. And the hallmark of that is attention deficits. People have problems with sustained attention. People have problems with divided attention, having difficulty switching from one task to another. It also causes impaired coordination. It slows reaction time. People have an altered sense of the passing of time. Information processing is slowed. So with all of these effects, you'd think that cannabis would impair the ability to drive a car. And there's good experimental evidence that this is the case. This is a study, a nice study out of the Netherlands from almost 2 decades ago now, Jan Romakers. And what he did was he instrumented cars with these little cameras on the roof, you can see there. And he gave people THC, cannabis, or placebo, and went on city streets and drove 100 kilometers. And as they were driving, he would measure a bunch of things. It was a dual instrumented car. There was a driving instructor in the car to take over if there was any problem. But what he found correlated well with impairment was he called the weaving index, how far cars move back and forth. And when people take THC, they weave more, sometimes to the extent that they can't stay within the lanes. And there's been other studies in high-fidelity driving simulators that show that people who use cannabis like crash, slower reaction times. There's suggestive evidence that cannabis should cause crashes. On the other hand, there's a hint in the literature that drivers can compensate. People who use cannabis are aware that they're slowed down a little bit, and they can take measures to minimize crashes. They leave more headway to the vehicle in front of them. Unlike alcohol, they're less likely to engage in risky maneuvers or aggressive maneuvers. So what we really need to know is what goes on in the real world. This is an example of one of the sort of classic study designs for alcohol of blood alcohol concentration versus the risk of crashing. This is a big study, a case control study from Fort Lauderdale. There have been a number of studies like this, and the results are all similar. At higher alcohol levels, the risk of crashes goes up. And you can see there when the alcohol gets to 0.08 would be our legal limit, 0.24 would be 3 times the legal limit. When you get up that high, you're talking about an increased risk of over 100 times, dramatically increased risk. And people have looked at this a little bit, dug into this, big numbers. These studies have thousands of patients. What happens with age? And this is the reason why we don't allow young drivers, novice drivers, to have any degree of alcohol. If you look at the solid lines, that's the risk of crashing in young drivers as alcohol increases. The dotted lines, drivers over the age of 21. And we know that younger drivers have a higher baseline risk of stomach growth, but that risk goes up even higher with alcohol, and that increase starts at lower alcohol levels, goes up higher. This is the kind of data we'd like to have for cannabis. The reason we have this kind of data for alcohol is because it's relatively simple to study. It has a big effect, means you don't need huge numbers. And it's also easy to measure at the roadside because of this device, the breathalyzer. And our breath alcohol content correlates well with blood alcohol content. There's an equilibrium in alcohol between what's in the blood and what's in the breath. Correlates well with impairment. It's easy to measure at the roadside. It's non-invasive. You get results back quickly. This is not available, unfortunately, for cannabis. And there's a couple of reasons why cannabis is so tough to study. To really do it right, you need blood. THC levels in blood correlate relatively well with recent use, relatively well with impairment. But blood is invasive. People don't like to have blood tests done. It's hard to get drivers at the roadside to volunteer to do it. People tend to refuse. That can bias results of studies. Lots of research has used urine samples to measure marijuana use. Urine doesn't even measure THC. It doesn't measure the active ingredient. It measures what we call carboxy-THC, which is a metabolite, an inactive breakdown product. The urine cannabis measures don't tell you anything about acute exposure. This can be positive for many days or longer after last use. People have tried, or people are trying to measure THC in the saliva, and it's non-invasive, and you can do that at the roadside. It's not as quick as alcohol. It takes a little bit longer to get a result. The problem is that saliva THC doesn't correspond with blood THC. The THC that gets into saliva is from contamination. If you smoke marijuana, it passes through your mouth. And what you're measuring is the residue of THC, of cannabis smoke, or if you ate a brownie or something, the residue that's left in your mouth. There's no equilibrium between what's in the saliva and what's in the blood. So if you were to smoke a joint and then brush your teeth and gargle really well, your THC levels are going to be lower than if you smoke a joint and don't do that. It doesn't correlate well with what's going on in the blood. It doesn't correlate well with it. To the point that it's not, it's basically positive or negative. But if you want to get an actual level, it's not helpful. So that's one of the big difficulties in studying cannabis. The other difficulty has to do with timing. The solid lines here, the solid red lines, are THC levels after you smoke a joint. And what you can see is the levels go up quickly. They peak at a really high level, typically above 100 nanograms per mil, and then they drop off rapidly as THC distributes out of the blood and into the body tissues, and then it drops off more slowly as it gets eliminated from the body. By 4 hours in an occasional user, THC is usually less than 2 nanograms per mil, and most impairment has resolved. Things are different in habitual users, and we'll talk about that. So to do this right, you want to get the right levels. quickly after the crash.
34 people.
Difficult to do. A lot of the research has been based on blood levels that were taken for forensic purposes. So police had to gather evidence. They did a urine test first, and then if that was positive, they got blood. And we're talking about delays of 3-4 hours. Harder to interpret. We really want to get this as soon as possible out. The other thing I just wanted to mention that I've become more aware of recently is something called post-mortem redistribution. A lot of the research on cannabis and crash risk has relied on coroner samples, dead people. And intuitively, you think that the level of THC that you measure in autopsy blood corresponds with what it was at the time that the person died. Well, unfortunately, that's not the case. In fact, it correlates really poorly. Blood, after you die, THC relatively quickly diffuses from the organs with high concentrations of THC into the nearby blood. THC is often concentrated in the lung, it's concentrated in fat and muscle, and so that you'll see rising THC levels after death. If you do it serially, you'll see the levels go up. And the THC levels vary dramatically depending on where in the body you get blood from. One study I saw, the THC was twice as high in cardiac blood as it was in peripheral blood, twice as high. So people who've looked at this have concluded that it's tough to interpret THC levels in living people. It's almost impossible in dead people. There's been a lot of research done looking at cannabis and crashes. There's been a number of systematic reviews. Mark Askridge from Halifax did one a couple years ago. There, the combined odds ratio was about 2, meaning about a doubling of risk. More recently, Ollie Rochberg from Scandinavia repeated this using slightly different methods. He found a really modest effect, an odds ratio of 1.3. But much of this research is done on people who are with major flaws. Autopsy samples that we talked about, long delays from crash until the blood was taken, case control studies with high refusal rates in both cases and controls, making it really hard to interpret. So we know a lot less about the risk of THC in crashing than what we'd like to. This is a study that we're doing, and we've completed sort of an interim analysis of this, which has been published. But this is a BC study, Cannabis and Motor Vehicle Crashes. We call this a culpability study. So a culpability study, or a responsibility analysis, compares everybody who's been in this study who's been in a crash. We make cases and controls depending on whether they caused the crash or not. So if the crash is fully explained by the driver, they're a case. So a crash that occurs on good driving conditions, a single vehicle crash, for example, there's really no explanation for the crash other than the person behind the wheel. That's a case. A crash that is happening out of the driver's control, that would be by other factors, that would be a control. So in the picture here, this is a graphic from Australia. Sorry, they're on the wrong side of the road, but the red car is slowing down to make a legal turn. The blue car isn't paying attention and drives into him. The driver in the red car is a control. He's been randomly selected to participate by circumstances out of his. That's what a case in a control is. It has to do with causation of the crash. We do that by analyzing police reports. And we look at factors that could contribute to the crash, the road conditions, the driving conditions, so forth. And we score these, it's automated, and high scores mean that there are lots of factors other than the driver that contributed to the crash. This is a control. Low scores mean the crash was caused by the driver, and this is. We've been collecting data, mostly from these 4 trauma centers in British Columbia since about 2011. So it's a BC study. How it works is most of these drivers are moderately or seriously injured. They come to hospital by ambulance. We get blood as part of our clinical investigations, usually pretty quickly. I was hoping we get it all within an hour. Turns out our median time is more like 90 minutes, but still much faster than previous research. And this is taken for clinical purposes. It's not taken for the purpose of the study. So it's not, I think this guy was using drugs. It's, I think this guy might have injuries. We need to do blood tests. We use usually the lavender tubes, the ones that are used to measure blood counts. And we're doing this with waiver of consent. So we have, everything is anonymized, so you can't track the results back to an individual driver. But we don't get refusals as a result of that. So it helps with selection bias. And then we get the BC police reports. Only after we get the reports, then everything's anonymized. So these are results from the first 3,000 drivers. About 2,300 had a matching police report. Unfortunately, police do not attend all collisions, even relatively serious collisions that come to hospital. Of those 2,300, we had definitive culpability scores in 1,825. For our primary analysis, we wanted things to be black or white, so culpable versus non-culpable, the indeterminate ones we threw out. We did sensitivity analysis and we included them, and the results were the same. This is a population of middle-aged men. So 2/3 of them are male. The mean age is 44. About 1/3 of the crashes are single vehicle. A little over 1/3 are nighttime crashes. And about 1/4 are admitted to hospital. The others are treated and released from the emergency. Our times are there at the bottom. The median time was from crash until blood draw was 84 minutes. And we got 77%, about 3/4 of our samples within 2 hours. So, much better than a mean time of 3 to 4 hours from previous research, not quite the 60 minutes that we were in. And this is the money slide. So the little dots are the odds ratio. A bigger number means a higher risk of causing a crash. And the tails out to the side are the 95% confidence intervals, the range of what might be of possible values from a study. So just look at alcohol, blood alcohol above 0.08, and you see this big risk, 6-fold increased risk of crash. And that's pretty similar, actually, if you combine all of the blood alcohol in the Fort Lauderdale study. I think they got about the odds ratio. So it's pretty consistent with that. And, if you're studying crash risk and you don't find an effect for alcohol, go back to the drawing board. It means you're doing something always in effect with alcohol. For alcohol between 0 and the legal limit, the risk is about double, odds ratio of 1.9. You can see it there. For other recreational drugs, we're talking cocaine, we're talking amphetamines, the odds ratio is 1.8 and 80% increased risk, statistically significant. For sedating medications, there we're talking things like sleeping pills, we're talking things like over-the-counter antihistamines, Benadryl, we're talking about some antidepressants. There the odds ratio is 1.5, modest increased risk, but statistically significant. For cannabis, things are interesting. If you look at that for the low levels of THC, 0 to 2 and 2 to 5, and our legal limits in Canada, our per se limit is 2, where fines kick in, and 5, where criminal code convictions and jail time can kick in. For those low levels, less than 5, there's really no effect. The odds ratio is 1.1 for THC between 0 and 2, 1.2 for THC between 2 and 5. Clearly not statistically, it just basically straddles that vertical dotted line. If you're on the left side of that, it means no risk. So really no effect for low levels of THC and fairly narrow confidence interval. For THC above 5, the point estimate was an odds ratio of 1.74, not statistically significant, relatively small numbers. So it may be, and we are continuing the study. We only had 20 cases in our analysis with THC above 5. It may be with bigger numbers, the confidence intervals narrow, you get statistical significance. We're planning another analysis when you get 6,000 cases, probably 6,000. So we'll see, but even there, not statistically significant, and clearly not the same problem as we're seeing with, right? Much smaller prevalence. 1% of our cases had THC above 5 compared to something like 12% had alcohol of 0.08. Smaller prevalence with cannabis and much less risk. Okay, so some people have looked at this and said that we've proved that it's safe to drive after using cannabis. No, we haven't. We just didn't find for the higher levels. I think there probably is a risk, and certainly the experimental evidence suggests that. And I would caution that things could change if the pattern of cannabis use changes. Young drivers, we saw for alcohol how their risk goes up so much higher and so much quicker. If you're an inexperienced driver and you're a little bit impaired, things can get a lot worse. So young drivers may be at higher risk, and if after legalization, this is all pre-legalization data, we get more young drivers using after legalization, things could get worse. Of course, there's zero tolerance. They're not allowed to have any degree of THC in their system. And when you combine alcohol with cannabis, things get ugly. In our sample, we had 44 drivers who tested positive for both, some at some level of THC and some level of alcohol, and 42 of those were culpable. So really that combination is bad, and if we see more of that, things are going to get. That's to do with cannabis and crash risk. This has been published recently. It's there in the Journal of Addictions. And if people want to visit our website, Road Safety and Public Health, we have a link posted to that. Next, I'm going to talk a little bit about a national study that we're doing. This is funded mostly by Health Canada. We had some funding from Alberta Transportation, Saskatchewan Government Insurance, and the Ministry of Transportation of Ontario as well. But we're analyzing leftover blood for toxicology now in all the hospitals with the red dots. I'm going to give you those results. And we're just expanding to include samples from Quebec, samples from Nova Scotia, Newfoundland, and hopefully Manitoba as well. That's funded by Health Canada. We have results since 2018. This is the first 2,200 patients. I think we're at almost 3,000 patients now, and we're going to publish that fairly soon. These are results from the first 2,200. So the bar on the far right, any substance, almost half of these drivers tested positive for some impairing substance, alcohol or a drug, and 42% of those were for some drug. And then looking at the other side, starting under alcohol, the salmon-colored bars, we see that 15% had been, 15.6% had been drinking, and 12% had alcohol above the legal limit. For cannabis, just to focus on the THC greater than 5, which is the group that we care most about, 2.4% in the national sample. That's higher than in the BC sample that I presented, but 2.4% tested positive for THC above 5 nanograms. 9% tested positive for an opiate, so that could be heroin. It could also be, prescription morphine or codeine. 9.1%. About 10% for a recreational drug, cocaine or amphetamines, and 20% for a sedating medication that we talked about, a CP pill, a benzoyl. Those are the overall numbers. Breaking that down regionally, I find this really interesting. And the results aren't what you might intuitively think. So that this is a range west to east. The dark bars are British Columbia, the yellow is Ontario, and then Alberta and Saskatchewan in the middle. The numbers from Saskatchewan are relatively small. We only had 100 cases at this analysis. We're about twice that now. But the numbers from BC, Alberta, and Ontario are quite big, so fairly narrow confidence. In terms of alcohol, we are British Columbia about 8% above the legal limit overall. In Alberta, about twice that, and then also higher in Saskatchewan. Just for THC, about 5, exactly the opposite of the sort of stereotypical BC bud smoking province. We're at 1.8% above 5 nanograms per mil, and it goes up as you go east. In Ontario, it's 3.3%. So it's not just the number of people who smoke pot, these are the number of people who smoke pot, drive a car, and get in a crash. For opiates, you see the numbers we are, and again, this is not what you'd expect given the heroin epidemic, the fentanyl epidemic that we're seeing, but we're the epicenter. In terms of driving a vehicle and getting a crash, we're a bit lower. Same thing true for sedating. Look at that according to age. The green bars are drivers under the age of 30, the gray are over the age of 30. What we see is kind of what I think you'd expect. The older drivers are more likely to have prescription medication, sedating medication. The opiates are a bit higher. Those are a combination of recreational but also prescription, higher in the older population. The recreational drugs and alcohol, higher in the younger population. That's kind of what you'd expect. If we look at alcohol by age, what you see is that at around age 35, people start growing up and stop drinking and driving, or at least it becomes less prevalent. So the lowest risk is in the drivers above 55. What's really concerning to me is the young drivers of 15 to 18. So here we had 17% of those tested positive for BAC. This is different than what you get at the roadside surveys. In roadside surveys, almost none of the young drivers tested positive. I think in British Columbia there was something like 1 out of 100. Ontario roadside survey, none of the young drivers, zero tolerance group, tested positive for alcohol. Now there's 2 reasons for that. One is the roadside surveys, people are allowed to refuse. So if you know you're breaking the law, maybe you don't want to have it, even though there's assurances that you're not going to be charged. Nevertheless, there may be that selection bias. The other thing is our studies drivers who are in a crash. And if you're 17 years old and you've been driving for 6 months and you've been drinking, you're above the legal limit, your risk of crashing is astronomical, and you're going to tend to come our way because of that. So we're seeing it's a different population, but still very concerning to me that we're seeing so many young. Cannabis, the pattern is, I guess, sort of similar. If you look at the THC, about 5, the highest group there is in the 25 to 35 range, and it tapers off with the older drivers. In terms of sex, what we find is kind of the pink bars are female, the blue bars are male, and what we find is that men, as we know, are more likely to drink and drive, more likely to use drugs and drive, less likely to use sedating. So again, I think this is kind of what you would be into. Injury severity, the greens are the drivers with relatively minor injuries who are treated and released from hospital. The red bars are drivers who are admitted to hospital. And as a general rule, substance use is more common with more serious injuries. That's been well studied with alcohol, but more serious the injury, the higher the prevalence of alcohol. I find this interesting, single vehicle versus multi-vehicles. This is sort of a hint of causation. It's not a full culpability analysis, but by and large, single vehicle crashes are more likely the responsibility of the driver versus multi-vehicle. And what we see, that the yellow bars are single vehicle, the gray are multi-vehicle. As a general rule, actually in all cases, substance use is higher in single vehicle crashes than in multi-vehicle crashes. And that difference is most marked for alcohol. And for alcohol, I kind of like this because this is just breaking it down by concentration. And as you see, the difference for alcohol about twice the legal limit. Single vehicle crashes about 5-fold more likely to be at that alcohol range than multi-vehicle crashes. So it really does suggest a cause and effect thing, and you even see the dose response there. When you look at that for cannabis, look at the highest levels, THC above 5, yeah, there's a difference. It's not the same kind of difference that we see with the polysubstance use. We don't have to dwell on this. This is just to show you that things are complicated. People don't use a single drug. People use combinations of drugs. They drink and they use drugs. They use cannabis and they use sedating medications, and there's various combinations and permutations. And the whole thing gets immensely complicated. We looked in particular at cannabis and alcohol. So the green bars, the green shaded circle are the prevalence of drivers testing positive for cannabis. Darker green is higher THC levels. Salmon color is alcohol, and darker color there is higher alcohol concentration. And then the overlap is people who tested positive for both alcohol and cannabis. And one thing I find interesting is that with cannabis, the higher the concentration, the lower the prevalence. So there's relatively few people, lots of people who test positive for THC. Fewer of those test positive for high levels of THC. For alcohol, it's the exact opposite. And we can't show it graphically within that, the overlap, but it's the same pattern there. So most of those are going to be relatively low THC levels, relatively high alcohol. But that overlap, that 5%, that's a high risk of crashing. Okay, so that's sort of the results of this study. We are in the midst of coming up, making a report for British Columbia, and we're going to be posting that on our website as well. So if people are interested, check there periodically. I also put Mel Masood's email address. If you don't want to check periodically, send Manel an email and we'll send you the report when it's available. In the last few minutes, I'm going to talk about these two issues. One is chronic users, and then I'm going to talk briefly about edibles. And then we'll have some time for a few questions at the end. So there are people who use cannabis occasionally, once or twice a month, and there's people who use it for medical purposes or people who are habituated to use it and use it every day. And I want to talk about that population that uses it every day. Two tricky things there. One has to do with the fact that these people test positive for THC for a long time. And I'm not talking about positive urine tests, I'm talking about positive blood tests. The sort of circled lines in the middle there show the prevalence or the percentage of drivers that are positive for THC after a certain period of abstinence. So the vertical axis is a percentage of drivers that are positive for THC. Horizontal axis is the number of days since they last used. And these are studies in a residential center. It's basically a secure research center. It's like a hospital with security. They can't bring examine when they come in. They can't bring any marijuana into it. And then they're monitored. And what you see is within the first 2 weeks, almost 60% of these chronic cannabis users test positive for THC in the blood after 2 weeks of abstinence. And it's not just at low levels. These people can have levels that are significant. So this is in plasma. So plasma THC levels are about twice whole blood levels. But if you look at the hatched bars are the 75% confidence intervals, and the horizontal axis is the number of days of abstinence. You see that there are a number of drivers with THC above 4 nanograms in plasma, which would be above 2 in whole blood, after days of abstinence. In fact, there are cases, relatively small numbers, but cases of people with THC above 5 nanograms after several days of abstinence. These are people who maybe use it medically, maybe are just addicted to it and use it multiple times a day, but they are going to be above the per se limit, even the higher per se limit, the legal limit, after a day or 2 days or several days of abstinence. The question becomes, well, they're above the legal limit, maybe they're impaired, And there is some research that suggests that in chronic users, there are some subtle cognitive deficits that exist and that are there for a prolonged period of time. The brain is still bathed in THC. Well, they're fairly subtle, and whether that's enough to increase the risk of crashing substantially is an open question. On the other hand, acutely, people who use THC regularly become less impaired after you smoke a joint than someone who uses it every day, someone who uses it occasionally. So an occasional user who uses once or twice a month, they smoke a joint and you do psychometric testing, they'll have a lot of impairment. For people who use it chronically, you don't see much impairment. There's a bit, but it's not as marked as what you're going to see in someone who uses it occasionally. So it's an open question about how safe these people are to drive. My sense is that the legal limits might be a little bit strict for in this population, especially the 2 nanograms per mil per cigarette. Okay, now I'm going to talk about edibles. So the edibles have just been legalized. They should be fully on the market because the products have to be approved by Health Canada by late December, starting in the new year. And it's going to be interesting. So one thing that maybe we aren't all aware of is so THC is impairing, and THC exists in edibles, of course. When you eat THC, it's absorbed, it goes into the liver, and it's metabolized to something called 11-hydroxy-THC. The reason I put that up there is that 11-hydroxy-THC is also impairing, equally as THC. And you get a bit of that formed when you smoke it, but you get more formed when you eat it. And you can get levels of 11-hydroxy-THC as high as the levels of THC. So someone's got a THC level of 5 after taking an edible. Just remember, you might have an 11-hydroxy-THC level of 5 as well, and they're more impaired than what you might think based on that THC level. So that's one tricky little tidbit with edibles. The other thing, which is probably more obvious, is that the time course is entirely different. So the blue graph here is the THC levels after you take an edible, and what you see is the peak is slower and it lasts for longer. So delayed effects and prolonged effects, which is kind of what we think. Now, how delayed? So 4 hours would be sort of typical, but how delayed depends on the form. If you take a THC infused drink, take that on an empty stomach, it's going to be absorbed relatively quickly, not as fast as smoking it, but it's not going to be a 4-hour delay, maybe a couple of hours. You take a rich hash brownie with a lot of hot brownie with a lot of fat in it, it's going to be delayed. If you take it on a full stomach, it's going to be delayed. It has to do with absorption time. The other tricky thing with edibles is it's easier to overdose. I put overdose in quotes because we're not talking about stop breathing and dying like with a heroin overdose. We'll talk about what cannabis overdose quotes looks like. But there's 2 reasons why it's easy to take too much. One is, what's the dose? If you smoke a joint and you start to feel, you get the desired effect, you can stop. If you start to feel a little bit too much, you just stop smoking. And it passes pretty quickly. But if you take an edible, you have to kind of guess at how much you want to take. And people aren't, maybe don't know, or maybe it's not labeled. A typical dose would be 10 milligrams, and that's what these candies show here. But you can have things that look exactly the same that have 80 milligrams, unless you read the label. And maybe you don't know what 10 milligrams means. And lots of times, if you're inexperienced, you take a bit, and you wait an hour, and nothing's happening, so you pop a couple more. And then you start to feel the effects of the first one, and it's too late to do anything about it. So it's easy to take more than what you want. And that's called greening out. And, a lot of that, it's uncomfortable. A lot of that is a panic attack. People feel anxious, paranoid. This is what we see in the emergency department. A lot of nausea, there can be vomiting, confusion. chest pain, shortness of breath, their pulse is racing, their blood pressure's up, they feel awful, and then it passes. And that can happen if you know what you're taking. But I mean, look at this. This is candy. And if you come home, I come home after work and I see a bowl of this lying on the table, I'm going to eat a few. I'm not going to look at, where did the wrapper come from? So it's out there, and it's very easy to take it without even knowing what you're taking. And if you feel a little bit panicky, if you know what's going on, imagine how you feel if you can't. And we see that in the emergency. We had a fellow, an older gentleman, whose son had some THC infused honey, and he drank that in his tea, and he was quite impaired. He was in the hospital for over a day with sedation. It started off with vomiting and sedation. There was an unfortunate, it ended up being okay, but a cleaning lady in a hotel who was left a tip. It was a gummy, 80 milligrams of THC. And if you read the instructions on the label, it said you're supposed to cut it into 8 pieces, and the dose is a piece. But who cuts a piece of candy into 8 pieces? She was hungry, and she didn't even know it had THC in it, and she ate it and came in vomiting and panicky, and then we're going to see, so that, this happens, and we're going to probably see more of that as it's just out there. And you can sort of imagine if you get all that panic attack and all of these other symptoms going on inadvertently while you're driving a car, bad things could happen. I'm certain it has happened. I'm not aware of specific cases, but imagine. And if you don't have this sort of wherewithal to get off to the side of the road and let it pass, you could have collisions as a result of that. So that's all I have to say. We can throw it open for questions in the last, we have lots of time, last 15 or so minutes.
So thank you very much, Dr. Brubacher. We now welcome questions and comments. You can use the feature on the webinar, or you can unmute yourself to ask a question.
Thank you, Jeff. That was a wonderful presentation. I'm flabbergasted with this labels and stuff, and I'm thinking, now that it's going to be legal and available, with kids getting their hands on it, and so I'm just concerned in terms of the cases that you've seen in the emergency. Like, what are you seeing that are coming in?
Well, we've seen a couple of cases. I told you those two, and there's the typical. Well, I guess there's two scenarios. There's people who know what they're taking, and they just took too much, and we do see that. We've seen that for several years, and you see that. I wouldn't say I've seen an uptick in that, but they come in with what sounds and looks like a panic attack. You can talk them down, give them a little, mild, relaxant, like Ativan, and they get better, usually. And sometimes quite sedated, and you keep them and let them up. And then you get the cases where people really have no idea what they took, and it's a little bit of a diagnostic dilemma because they can present like they're having a heart attack. They can, if they're having chest pain and their blood pressure and pulse are up, and they look kind of sick. They're vomiting, maybe they're having a heart attack or some medical catastrophe. But then when the dust settles, you find out that they test positive for THC and you've never used, and it ate something that might have been suspect, and you kind of can focus in on it. Because generally speaking, it's not a dangerous overdose in the sense that people don't die from it. They don't, and people don't have serious adverse effects. It's something that you can treat and it passes, unless they get into an injury or something because of bad judgment. So it's something I think we need to keep looking at. I think it's a bit more of an issue in children because smaller weight, bigger doses, they could get more sick with it. I think you get prolonged coma and decreased level of consciousness in kids. That might be more of an issue than with something that has to be monitored.
And will you be incorporating any of the testing in the study for edibles?
Well, I have a meeting at the end of the month with the guys in the forensic lab, and I'm going to try to get 11-hydroxy THC added to the blood testing that we're doing. That's not under, like you can't, there's no definitive test for edibles, so you're going to get 11-hydroxy in blood after you smoke it as well, but apparently higher concentrations in it. We might be able to make some comments about 11-hydroxy THC, but really to know for sure you have to ask. And our protocol, because we have waiver of consent and because everything's anonymized, we can't ask. So we won't have that.
In terms of public health and prevention concerns, what would you suggest?
So, well, let's talk about, just the message for cannabis and driving first of all. I think there's two messages there. So even though we showed that low levels of THC probably aren't associated with much increased risk of crashing, the safe thing is to leave a period of time between when you use. I would say a safe period of time for smoking, 4 hours. If you took an edible, that time window is longer, maybe 8 hours. And if you're feeling the effects, any effects, you shouldn't be driving. I think that's sort of common sense. The second thing is be aware that any combination of cannabis and alcohol is high risk. So you just can't mix them and drive. Obviously, alcohol is a huge problem, and all the teaching around don't drink and drive, it still exists, but it goes double if you use any degree of cannabis. No questions out there in cyberspace?
Aaron says, it seems like the major determinant of impairment is tolerance. Is there a reliable way to determine usage habits or tolerance in your study population?
So no, the short answer is no, there's not. We don't, to do that, well, you'd have to interview the drivers. And our study doesn't, our research ethics doesn't allow us to do that and have waiver of consent. One thing that we will be looking at is the carboxy THC levels. There's the suggestion that people with really, really high levels, so that carboxy THC is the metabolite. People who have really high levels of carboxy THC are more likely to be habitual users. And habitual users are more likely tolerant. So when we get bigger numbers, we are going to do a separate analysis where we look at, divide people into a high carboxy THC group and a low carboxy THC group and see what happens in those two groups.
And what are your next steps moving forward from here?
Well, we're just starting to launch that study, the prevalence study across Canada, so we're really excited about that. We have 2 years funding. I'd like to make that a little bit long because I think this is a great way to monitor things. So we're going to be doing that. We are continuing here in British Columbia, and we're hoping to get 6,000 cases with more cases with high THC levels, and we'll rerun the culpability analysis. And so hopefully we'll get a bit narrower confidence intervals, so better estimates at the higher levels going on there. Those are our two big things. Million and one other things, but I think that's kind of the key.
And in terms of your data collection and stuff, you're focusing more on the trauma centers. Do you think that there are any cases that you would have missed, that you would have gone to the other hospitals that you wouldn't come across?
Yeah, well, yes. So we're focusing on trauma centers for practical reasons. And the thing is that these are high resource intensive study. We have to check the census every day or every 2 days to identify drivers that have That requires a research assistant in the hospital assigned to that hospital doing that. If you do that in a center that has 2 cases a month, it just becomes inordinately expensive per case to do it. So that's the reason that we're doing it. And we sample because, so the cases that we are likely to miss are going to be the cases from, more remote areas that are far from a trauma center. So either they have a minor injury and never go to a trauma center, they're treated at the local hospital, or they have a major injury and they're transferred to the trauma center, but they don't arrive for many hours. And the THC levels are already gone. Those aren't helpful for us. So we are missing those. And, there's reason to believe that the prevalence is probably higher in rural areas based on the roadside survey, for example. So we might be missing some of that. But 85% of Canada's population lives near a population center. So what we're studying applies to the majority of the country.
If there's no more questions, then we'd like to thank Dr. Brubacher for your time and everyone that joined us today. Our next webinar will be held Thursday, January 23rd on concussion awareness recognition and return to work. Our presenter will be Ms. Denise. Details of the webinar will be available via the BCR and PUE newsletter website. And we look forward to having you. Bye.